the concept that I hope everyone takes away, is the idea of volume overload is critical. And I feel confident in saying that most people are discharged from emergency rooms or hospitals in the United States and they are not adequately compensated, period. They still have excess fluid. And remember, what you're doing with something like a diuretic is great, but you're only mobilizing intravascular volume. So it doesn't mean they're still not volume overloaded, even though the creatinine may jump a little bit. So these are important concepts when we talk about this, and we know if they're not adequately decongested, they will come back. So this is an important component to heart failure management that I don't think we pay a lot of attention to, because as practitioners, we're all under the gun to get patients out of the emergency room or out of the hospital. And if there's a way that we could do that more effectively and maybe less than that 5-day typical hospital stay, I think that would be an effective opportunity that would probably make everyone happy. So I'll turn it over to the team to talk more about the real world experience. And I'll just throw in our own little caveat, is that we've had similar experiences to what you will hear about. And we've actually reduced our 30 and 60-day readmissions by nearly 60%. So we do believe that in the right hands, this technology can be essentially a game changer for how you manage inpatient heart failure.
So we created a comprehensive heart failure team, to which 3 out of the 4 people that are listed on this paper have been together since the beginning of this program. That's Maureen, Hummel, and Patti Barrella. 2012, Dr. Haas was hired to be our advanced heart failure physician to advance our mechanical circulatory support as well as our heart failure team. But in saying that, we've been learning for the last 13 years how to best utilize aquapheresis in our patient population. And so that when we'll talk about the randomized trial data here in a second, you have to realize this only encompasses about 3 to 4% of the patient population that we treat on a routine basis. But in saying that, it has been able to demonstrate that 3 to 4% of the population have improved their readmission rate and their survival rate significantly with the utilization of this technology.
Bulimic weight of this patient. Historically, I think what happens between all medical providers is they look back at what was the weighted discharge of the previous hospitalization for heart failure when they were volume overloaded. And, as we all know, we don't do a great job of decongesting, so that weight at discharge is faulty to begin with. And so really drill down, discussion with that patient. What was their weight? Maybe it was 9 months ago, when they had no edema, when they weren't short of breath. And wow, it's not just a 15-pound weight gain, it's a 45-pound weight gain from the last time they could actually portray a euvolemic state.
In addition to confirming what you think their intravascular volume status may be, and of course sometimes you can be surprised by that, you learn what the cardiac index is. And even if their index is down, it doesn't mean that you can't do ultrafiltration. But it often means, in our experience, definitely need to have some kind of support, either with milrinone or dobutamine, in order to get them through the ultrafiltration session.
It's typically going to be better. And how could you identify patients that are diuretic resistant? I think a lot of people have been faced with someone who's been in the hospital for 10 days, 50 pounds overweight, who've been slammed with diuretics, the creatinine doubled, and now they're calling you for ultrafiltration. Well, that substrate's not as good as it could have been if they would have called you on the front end. So the identification of these patients early makes a huge amount of difference.
The majority of the time we will reinitiate loop diuretics at 50% or less of their pre-hospital rate with the similar response. So there's a lot of people doing some research on neurohormonal deactivation and various biomarkers that we watch routinely to determine appropriateness of therapy.
I think that what we have seen is patients who come in with more volume because they have avoided us for this period of time during COVID. So I think what we're seeing right now on our heart failure unit is patients who we may know from the past who are simply just more volume overloaded and would actually benefit from ultrafiltration and aquapheresis. because they just delayed seeing anybody. So we're seeing them for the first time with lots and lots of volume.